Okay, hello. Good evening, everybody. My name is Sherry Mizumori, and I'm the chair of the psychology department. And I have the very distinct honor of welcoming you to the second of our Edwards Public Lecture Series this year. As you know, the title of this year's lectures is the transactional relationship between mental health, research, and care. And in particular, tonight's two lectures will focus on the topic of getting care to those who need it. Now, before I introduce tonight's speakers, I just want to say a couple words about Alan Edwards himself. In case you didn't know, he was actually a former faculty member in our psychology department for 50 years. He stayed here from 1944 up until he passed in 1994. And of course, he made huge contributions to science in the field of statistics, but for the department, he left a lasting legacy by endowing this lectureship that will allow us to bring famous sort of national as well as international speakers here to the University of Washington in psychology, which will help us then stimulate the intellectual climate in the department for all faculty, staff, students, and also the public. And so we thank the Alan Edwards family for that. Now, our first speaker is Dr. Vibe Forsyth Cox. She is an associate professor here in and director of the Marshall Linehan Clinic here in the psychology department at University of Washington. She's the director of the DBT, or Dialectical Behavioral Therapy Clinic, and she is a licensed clinical psychologist as well. She is a DBT Linehan Board of Certification certified clinician, and she provides clinical services in a number of different groups, including Veterans Affairs Medical Centers, the University Psychological Services Center, different outpatient clinics, and even maximum security forensic inpatient settings. Now, Dr. Forsyth Cox also teaches courses and provides supervision to advanced graduate students here in the department, and where she delivers DBT kinds of training. Dr. Forsyth Cox is also a trainer and consultant for Behavioral Tech LLC, or BTech as it's called. This is a training company that's founded by Dr. Marshall Linehan, and this provides training and consultation for DBT clinicians internationally. Now, Dr. Forsyth Cox is also a member of the board of the International Society for the Implementation and Teaching of DBT, and there she is a founding member of the Society's Anti-Racism Committee. Now, Dr. Forsyth Cox is also very passionate about increasing equity in mental health treatment and provides consultation to providers interested in doing more anti-racism work in their DBT clinics. And so with that, I'd like to now welcome Dr. Forsyth Cox.
Thank you, Sherry, for that introduction. One thing you may have noticed is that my introduction included a lot of roles where I do teaching and training. And I wanted to give you a little context about that. So I first learned about dialectical behavior therapy in my interview for graduate school. I was interested in borderline personality disorder, and I was talking to my would-be advisor, Dr. Jennifer Chevins, and I was interested in thinking about the complex problems that these individuals faced. And Jen asked me, well, have you heard about DBT? And I learned that there were people who were at high risk of dying by suicide, who were looking for treatment, who were on a months-long waiting list to see advanced graduate students in a training clinic. I learned that because of the kinds of problems they experience, the high risk of suicide and some of the other problems that are associated with that diagnosis, that providers were afraid to treat them. And so this fear and this stigma was leading to people who were suffering, struggling, and needing help, not being able to get help. And I thought, if people knew that there was an effective treatment, this treatment that worked, and they knew how to do it, then surely they would be willing to treat this population. So I figured I would learn the treatment, and then I would try to help others learn it. And that's how I got involved in doing DBT and in doing the kind of training and teaching work that I do. And so To give you a little bit of context, any conversation about DBT is a conversation that probably includes mention of suicide and self-harm. So, we'll start there. So, according to the Center for Disease Control and Prevention, in 2021, there were 1.2 million suicide attempts globally. Of these attempts, about 46,000 people died. Aside from attempts, there were actually about 3.5 million people who planned a suicide attempt, and 12.3 million people who thought about it. This is a lot of people who could potentially benefit from getting the right treatment. So, over 40% of individuals who attempt suicide do not receive mental health care. And half of those who do receive treatment perceive some kind of unmet treatment need. So even if they get in to see somebody, they still have the experience that all their needs aren't being met. Those of you who are familiar with Dr. Linehan and her work know how devoted she was to trying to help people get out of this suffering. And so what she did at the beginning, in the very beginning, right, she learned the best treatments that were available at the time. She devoted herself to learning what was available so that she could do treatment and help these people who were suffering. And what she found doing these treatments is that it still wasn't enough. There was still something missing for this population. And this is what led her to work on the development of DBT. And so at its core, DBT really is an attempt at increasing access to mental health treatment for a population that wasn't being served. So the first randomized control of DBT that demonstrated its effectiveness for this population was in 1991. And in those years, since it was first developed, it has actually been shown to be not only effective for the population of people with borderline personality disorder, but effective for a wide variety of presenting problems. One of the things that Dr. Linehan brought to the scene was a set of fresh eyes and lived experience, and thinking about suicide as not just a problem to be solved, but an attempt at a solution. The solution being a life that was unbearable as it was currently being lived. And so with that conceptualization, it shifts our attention to trying to help people figure out how to solve the problems that if they solved, they could have less suffering and more of the things that they want in their lives. And then if they were able to build a life that they wanted to live, then they would no longer be motivated to end the life. So this was the approach to developing this treatment. The research supporting DBT is strong. And strong research base is actually not enough. People have to be able to get the treatment. And so I imagine, because you're here, you have some interest in this idea of increasing access to mental health care. So when you think about increasing access, what are some of the things that come to your minds as barriers to mental health care? What's in the way? Yeah? Money and insurance, right? In a survey conducted in collaboration, CNN and the Kaiser Foundation actually did a survey, and they found that when asked, 80% of Americans say the cost. The cost is a big concern. People were allowed to give more than one answer. So what else? What else is in the way? Stigma, right? Attitudes about mental health care. Actually, one of the other big barriers, especially for people who are experiencing mild to moderate problems, is they have the thought, I want to figure it out myself, right? I know I have this diagnosis, I know there's treatment, I can figure it out on my own, and that stands in the way. But we find that those kinds of attitudes about care, That's really for the people who have mild to moderate problems. For people with more severe problems, there are a few other things in the way. There are more structural barriers in the way. Therapists wait lists to receive treatment. So, even if you know about mental health care, and even if you decide you want to go, and even if you have the money, you have to find a therapist to treat you. And even if you find a therapist to treat you, that therapist might not actually specialize in taking care of the problem that you are trying to go to therapy to solve. So there are actually quite a few barriers along the way, along that journey, to actually getting treatment that helps. Because we talked about in the earlier slide about people experiencing that there's some unmet treatment need. I think I have a number here. 55% of people say that it's a big problem that there aren't enough mental health care providers, that that's a big part of the problem for them. What else? Yeah?
Lack of providers who share your minority or multiple minority identity.
Absolutely, right? This is a big part of the fit for treatment. So for when people are looking for treatment, there's enough stigma, there's enough embarrassment, there's enough risk of not being understood already standing in the way. And so people often look for a provider who shares some aspect of their identity because it helps people believe that this provider might have some insight to provide, might be able to help them with the unique problems that might be experienced by that community, or at the very least won't say or do things that cause harm. About 23.9% of the respondents said that they dropped out of treatment because of negative experiences with their providers. So let's talk about these categories of barriers to access to treatment. So one is the cost. Mental health care costs are probably the most commonly discussed barrier to treatment. Sometimes people have insurance that helps them pay for treatment, and sometimes they don't. Even when people have insurance, sometimes insurance doesn't cover the full cost of mental health care, or it might not cover a provider who has the specialty that you need, that you're seeking. So cost can be a big barrier. And sometimes people don't even look for mental health care because they have a belief that they would not be able to afford it. In terms of identifying appropriate care, this is the category that covers that idea of not only do you need to find a therapist who has room on their caseload, you also need to find a therapist who is trained in the kind of intervention you need. And sometimes, especially if you live in a more rural or remote area, it's really difficult to find that combination. You might not even have a lot of providers near you, much less somebody who is doing that treatment. I've actually encountered several families who traveled as far from Spokane to receive treatment because there were not providers closer to them who were capable of providing the treatment that they needed. Right? And so people are put in this position of also just physically being able to access care. And actually being able to do care through telehealth has increased access to mental health care for a lot of people for whom proximity was one of the major barriers. So back to the DBT part of the story. One of the things that came from Dr. Linehan's development of DBT was a treatment for people who had previously been considered untreatable. So this was a new idea. There was a population, there was a group of people ready and waiting and in need of treatment. And so part of Marcia's devotion was to be able to find ways to get these treatments to those people. And so the label, what we call that in this type of research, we call that dissemination of the treatment. Right? Getting the treatment out there to the people who need to receive the treatment. And so what that meant is the people who had the opportunity to learn DBT from Dr. Linehan also kind of got deputized, right? If you get to learn from me, that means you have to go out and teach other people so we can get this treatment to as many people as possible. And that created this hub at the University of Washington where people knew that they could go to get information about DBT. So researchers, we still field emails and calls and inquiries that are directed to Dr. Linehan for people looking for information about how to do research and expand the research on DBT, people who are looking for connections to training in lots of different countries. DBT, there are now functioning DBT teams, according to the behavioral tech materials, functioning DBT teams in at least 62 countries. And so people are looking from all over the world to be connected with this treatment, ways to learn it and ways to get the treatment. And so the University of Washington has really played this role, and the people who train in the clinic, it's been a part of that training to learn how to help teach others. And this is part of the reason that I think the model of our DBT training clinic and the model of the clinics that Dr. Linehan ran is a model for increasing access to care, right? Because that's part of what has to happen when you have a new treatment. So Dr. Linehan's legacy includes evidence-based treatment. Dr. Linehan was a strong proponent of making sure that this treatment got studied. Treatment, related treatment, adaptations of the treatment, which parts of the treatment are most effective. If there is a question, we can answer it by doing more research, because that will help us figure out how to make it the most effective we can make it for the populations who need it, right? If there's a slightly different population with slightly different needs, we can also figure out how to best serve that population. And so evidence-based treatment and asking those kinds of questions and reviewing the treatment itself has been a part of this current of the DBT community. Also, rigorous training. The stakes were high. You have people who are at risk of dying by suicide, and they are being treated sometimes by graduate trainees. And so that means these trainees have to be ready. Right? And so the training, which I can talk a little bit about if we have some time, I can talk about our training model at the clinic, but rigorous training is also a big part of this undercurrent, which also we'll get to when we start talking about making sure that there are providers who are trained in specialized treatments. That's where this piece can come in. And then also getting treatment to the people who need it, so providing accessible services. Part of this is that Dr. Linehan didn't want cost to be a barrier for the treatment. The clients who are diagnosed with borderline personality disorder and are struggling with some of those presenting problems often have problems that get in the way of maintaining stable employment, sometimes get in the way of maintaining stable housing. And this idea, a piece of this idea that I want to take away from this is something that I learned through being trained in DBT, is that we don't want the problems that people are coming for help with to be the reason they can't get treatment. So if you can imagine somebody who is in substance abuse treatment, and they are using substances to the point where they sometimes miss appointments. If they get kicked out of their treatment program for missing appointments, then they have been kicked out of the program for exactly the problem they're trying to solve. So they can't get access to treatment because of their problem. And so this is something that because of the way it shows up in the borderline personality diagnosis and other diagnoses and related problems, this is something that we have practice thinking about in DBT, is how do we not let the problems that people are experiencing be a barrier to treatment? So if people, let's say, miss appointments, or if people aren't able to hold stable employment, that might get in the way of them being able to pay. And so being able to provide treatment, one of the things that I've heard Marcia saying is, if somebody can only pay $1, then they pay $1. And then when we help you with this treatment and you get a job, you can pay us back. Right? If we do our jobs, you'll be able to pay us back. And so one of the things that we've been able to do at the current clinic with the support of generous donors is to be able to make sure that people aren't turned away from care because they don't have the ability to pay. In training clinics, people generally pay a fraction of the cost that they might pay in an outpatient private clinic. And making care cheaper still doesn't mean that everybody will be able to afford it. And then even the cost of care, sometimes there are costs associated with transportation, with parking, with all of the things that enable people to actually get to their therapy appointment. And so these are all problems to be solved. And ideally, problems that people can get help solving when they get to the right kind of treatment. Also, we'll talk a little bit later about providing supportive resources to the community. So this is the part about increasing access by increasing knowledge. One of the things I'll tell you a little bit now that we've been able to do is I currently teach a suicide risk assessment and management course. It's a similar course to one that Dr. Linehan used to teach. And this is something that even if a provider is not doing dialectical behavior therapy, it is still an important skill set to know what to do if someone comes in front of you and tells you that they have been thinking about suicide, right? And so these are skills that translate across different types of treatments. And so being able to offer these courses at the university and also make them available across disciplines and hopefully in the future in educational experiences for the community is another thing that we can do to try to increase access to the kind of care that people need. Okay, so building the bridge. This picture was actually taken right here in this corner at Dr. Linehan's retirement party. So Dr. Linehan retired from the Behavioral Research and Therapy Clinics and the Treatment Development Center in 2019. And in September of 2021, right at the end of my maternity leave, I started as the inaugural director of the Marsha Linehan DBT Clinic. And in January, we led our first DBT skills training group, and we're able to start delivering treatment very quickly. And I credit that to the support of the incredible graduate students at the University of Washington. If I didn't have students who, when I came in, said, great, sign me up. I've been doing this external practicum. It's been amazing. I'm ready. Put me in. Right? We had incredible students who were ready, signed up to go, and that's actually how we were able to start delivering the treatment so quickly. We've also had amazing supervisors who volunteered their time to support the clinic. And so, you know, they've been able to help us maintain what Dr. Linehan had built that had been on pause for a little bit after she retired, but we've been able to pick up and continue doing that work. So a little bit about our work. Our clinic is primarily a training clinic. This is a place where advanced graduate students learn to deliver the therapy. So we have didactic courses. I talked a little bit about the suicide risk management and assessment courses. They're also able to watch videos of experts delivering the treatment. Because of the research that Dr. Linehan did, we actually have lots of video recordings of experts delivering the treatment that students can actually watch, learn how to do a first session, learn how to do a second session, learn how to address this problem, how does this expert address this other problem, so that they can prepare for doing their sessions. All of our trainees begin with one-to-one supervision, and just for a little note about supervision, because it's also something that I'm passionate about. One of the things I really appreciate about the supervision that we do in the clinic is that our supervisors watch recordings of sessions. And this is important because when students are in training, they don't know what they don't know. And so a student can come to their supervision and say, I had a problem with this. I asked the client, you know, what happened, why they did this. All they would say is, I don't know. And even if I gave them options, they didn't know. And I need help. I don't know what to do. Okay, so we watch the tape. Watch the tape. The therapist might ask the client, okay, so what do you think contributed to you doing that? The client says, I don't know. Now see this part right here where there's about 1.5 seconds before you start talking again? This actually might be contributing to why the client is not giving answers. There might not be enough space. People take time to think about things, to think back on things. And so being able, try leaving a little bit more space here and see if you can get a different kind of response. That's the kind of fine-grained, behaviorally specific feedback that I think results in students getting to proficiency in delivering the treatment more quickly, to be able to have someone look at the whole scope of the behaviors, look at what they're trying to do. Our supervisors also work on case formulation with the students to talk about what are the problems that this person is coming in with, what might be the problem that if we make change on this, it might help us change the other things. And so they really get that experience along the way of putting the treatment together. Our trainees also are very fortunate that they get to attend a lot of trainings that are actually geared toward licensed providers who are already practicing. So they get to not only observe those trainings, but to learn from the questions those providers ask, the troubles that they're running into as they learn to deliver the treatment. So it's an opportunity we're very fortunate to have. Our students also go to the amazing DBT practicum sites in this area because this Seattle, Washington area is the cradle of DBT. And so there's a lot of strong dialectical behavioral therapy treatment in this area, and our students get to benefit from that. Okay, I think this was actually on a slide that was circulating before, just to say that DBT is delivered in 4 major modes of the treatment, because later I'm just going to talk about the treatment that we offer in our clinic, so it's just for context. Right here. So in our clinic, we're offering a comprehensive DBT program. That means we have all 4 modes of the treatment. So our students deliver individual therapy, the skills training, the consultation team, and also between sessions coaching. And so what that means is that our clients are learning new skills to solve the problems that they've been experiencing. It's one thing to talk about it in a session, one-on-one. It's another thing to be in that conversation with your boss at work, and you're trying to control your emotions, you're trying to think of what to say, you don't know exactly what to do, you know you can't do the thing you usually do because that's how you got into these problems. And so in that moment, you can actually call your therapist or contact your therapist some way to actually get coaching. The therapist can say like, perfect, so glad you called, this is what we talked about. Why don't you try X, Y, and Z and see how that goes. That way, it's more, I think, my opinion is, it's more efficient because rather than doing or saying something that leads to another problem, and then you have to wait 4 days to go into your session, think back on it, think about what might have gone wrong, talk about, try something different, and then wait for another confrontation to see if that change in strategy works, you can actually get help to do something different in the moment. As you can probably imagine, this is pretty stressful for trainees to be called, but these are my trainees here, they're like, it is, to be called by surprise and be expected to think up a way to help this person with their problem. And so this means that our supervisors, for the most part, are also on call. So my trainees know that they can call their supervisors, they can call me and say, okay, the client said this is the problem, this is what I was thinking, what should I do? And so they actually also get help working on those in-the-moment types of problems. So we talked a little bit about the education already, the coursework. We have a variety of supervisors. And so students not only learn from me, but they learn from other people. It's a principle-driven treatment. And so even if we all believe the solutions should work the same way, we might have a different way of organizing our plan, different way of implementing them. And so I think this is a real benefit to our students because they don't have to just rely on one person saying, this is the way you do it. They can actually talk to a few different people and see what those different perspectives are so that they understand the core of what's important. Another unique and exciting thing about our clinic is student financial support. So again, thanks to our generous donors, we are able to offer teaching assistantships, research fellowships, and clinical fellowships. And what this does is that in a place where students might have to take on other types of work to be able to support themselves through graduate school, we can actually offer this funding that helps them focus their energies on something that's related to what they're trying to learn. So that's what these fellowships and assistantships support. One of the things I was really hoping to talk about in this presentation is how we are equipping these students to be leaders, to be able to teach and train, develop trainings, help build resources in the community. And I thought, What a great opportunity to help expand their leadership skills. So instead of talking about my students, I'm actually going to have a few of the trainees talk to you about their experiences in the practicum. And so we'll start first with Li Ying. You change the order? I think we said me first. Okay.
I'm a fourth-year clinical psychology PhD student here, and it's beginning my second year as a practicum student with the Marshall Linehan DBT Clinic. So in addition to learning the treatment and seeing clients as an individual therapist and group skills leader, I've also had the privilege of serving as clinic coordinator for the past several months. So this means that I field all of the email and phone requests that come into our clinic from all over the country and really all over the world. I've been financially supported through the clinical fellowship and now the DBT TA, which means that I have dedicated time to devote to corresponding with people about the barriers that they face in finding treatment and working to find solutions, dedicated time that's probably hard to find in some other clinic settings. One of the most common barriers that I hear from folks about is just being unsure of where to look to find a DBT therapist in their area, which is a fairly simple barrier for us to overcome given that we're a hub for DBT in this area and really all over the country. So I'm happy to direct people towards resources and directories for therapists. I also work to offer alternative treatment referrals for people who we are screening at our clinic and we determine a different treatment modality might be a better fit. Working as closely with Vibe as I do, I've gotten valuable perspective on the behind-the-scenes logistics of running a clinic, which has been really valuable for me in thinking about what I want to do post-graduation. My hope is that by investing time now in clinical skills and administrative skills, I'll be well poised to devote more time to directly providing clinical care post-graduation and maybe training others one day. And in the meantime, I just really enjoy having dedicated time to hear people's stories and connect them with next steps for care. I'll pass it on to Emma.
Hi, my name is Emma Pakanga, and I'm a fifth year in the program, and I'm a member of the practicum, so I see an individual client for DBT-PE under Vibe supervision, and I also attend our weekly consultation team. And so as Vibe has already detailed, our clinic is structured in a way such that all four of the components of a comprehensive DBT model, all of them are structured in a way that everything is a learning experience. But I think that that general theme applies to the clinic as a whole. And so I think that's most exemplified in our resource center and consultation pieces. And so each week we have an admin meeting in addition to having just a consultation team. And in that meeting, we not only talk about referrals, getting people into our clinic, but also field other requests from the community. So requests for information, requests for trainings, et cetera. And Vibe leads these meetings in a way where she garners input from each of us and solution analysis from each of us, but she also essentially models her decision making in what we do when we are asked for information from across the world and from our community. And so we kind of all run the clinic together in a sense. So not only does this teach us how the nuts and bolts of running a clinic, a DBT clinic in particular, but also it helps us grapple with and consider how to hold our responsibility as leaders in our community to both increase the accessibility of the knowledge that we hold, but also to retain the integrity of the original DBT program. And Lauren's going to speak a little bit more to this and an experience that stemmed off of that weekly admin meeting. Thanks.
Hello, I'm Lauren. I'm a fourth year student in the program, and I have been in this DBT practicum for almost a year now. And through this admin meeting and through the practicum, I had the really unique opportunity of providing consultation to a local police department about a community member who was really frequently using emergency services to respond to suicidal behavior. And this was a really significant problem, both for the department and the individual, because emergency services isn't designed, it's not structured, and the personnel aren't trained to provide this kind of ongoing intervention for suicidal behavior. And so at the same time, that's what they were having to do, and they kind of ended up in this de facto provider role, but without the training and experience to really address this behavior and address this individual's needs. And one of the major contributors to this that was identified by the department was the lack of local treatment options. So I think the nearest provider with expertise in suicidal behavior was over an hour drive, and that's not even considering the wait list. And so the thing that the department was really looking for in our consultation was what they could do to help reduce the suicidal behavior and what ways they could provide support to this individual that weren't going to contribute to such an undue burden on the resources and on their personnel. And so this experience really made me think critically about what accessibility means, beyond just the number of direct providers, but where they're located and what their expertise is, and really the scarcity of, as Vibe was alluding to earlier, the scarcity of services in a lot of places for high risk and high need populations. And so that's something through this experience that we've talked about as a DBT practicum team in these admin meetings about what things we can do to help alleviate this gap and what resources we can develop so that we can get these kind of de facto providers in the community the knowledge and the tools they need so that when individuals are in crisis, they can respond effectively and compassionately and help direct them to the appropriate evidence-based care. And along with that theme of accessibility, I'm going to turn it over to Ling, who's going to talk some more about things that she is working on around accessibility.
I am working on developing a mental health intervention program based on DBT to address mental health needs among people living with HIV in China. Throughout this process, I work closely with my community partners in China to identify their needs, as well as consulting with Vibe regarding selecting DBT skills, tailoring them to the cultural context, and also developing training materials for the staff members in the community. So this intervention consists of two components. One is individual skills learning through an app. The other is staff-facilitated skills training group. Through this project that I'm working on, which is also my dissertation, I'm hoping to disseminate DBT skills as evidence-based treatment resources for people who are in need in China and also worldwide, thanks to my supervisor Vibe and also my colleagues at the clinic. This is something I've been working on for the past few years. Yeah, thanks.
Thank you all. I am very proud of our students and the work they've been doing to increase access to care. One of the things that I am the most, I think, honored to witness is the fact that I didn't have to inspire them to be passionate about connecting people with access. And so when people call the clinic and they call Kate, who is the clinic coordinator, and they describe the problems they're experiencing, I am not the one who had to ask Kate to help connect them with other types of treatment and types of services. Sometimes the thing I have to do is remind the trainees that they cannot solve all of the world's problems immediately. That's actually something I do more frequently than encouraging to do more connecting, because they're looking for, as Kate said, what is the best treatment? What does this person need? They're willing to volunteer, like Lauren did, to develop resources that can be useful in the community and get care to people who don't need it. Ling was already passionate about expanding care across the globe before I met her. Emma also learning how to be the best DBT PE therapist she can be. She's so open to feedback that it is actually easy to give her the kind of feedback that I know will make her proficient as a therapist and make sure that the people who are in her care are getting the treatment that they need for the problem that has been identified. And I think that this is the unique opportunity of training clinics, to actually capitalize on the passion that already exists and equip people with the knowledge, the tools, the understanding, and the practice to be able to solve these kinds of problems in the future, to be able to help direct someone to the treatment, even if that treatment is not the treatment that you give, right, is an important tool for increasing access to mental health care overall. So this is a recap which is good because I'm running out of time. A recap that our important factors that we were trying to impact were cost of treatment. And that is something that training clinics, again, are uniquely poised to do because they can also be subsidized in different ways. So not only are trainees not paid at the rate that licensed providers are paid, which in itself is an equity issue that we've got lots of smart minds brainstorming and working to resolve. Also, training clinics can be subsidized with the help of donors. People can make donations and say, I would like this money to go to making sure that someone is able to pay for their sessions. There are also sometimes grants that are available for training clinics. And what that means is that the burden of paying for the running of the clinic doesn't fall on what you're charging clients for care. And so the treatment doesn't, or the clinic doesn't rely on what the clients are able to pay for its full operation. We talked about identifying appropriate care and increasing the availability of providers by not only training people who will see clients directly, but also by increasing the capabilities of the other providers in our community. By providing resources to the police department that we worked with, we've actually increased their capability to figure out how to respond in a way that might result in that person getting a kind of care that is more likely to result in an improvement in their life and hopefully prevent them from being in a situation where they take their lives. So the idea here is that by investing in training clinics, we actually have the opportunity to begin a ripple effect. So I am somebody who has done a lot of direct therapy. I've done training, I've done consultation, supervision. I'm working with these trainees now, and I was inspired, and I had my foundation in a graduate school training clinic. Right? The person who taught me also had their foundation while they were in graduate school. This treatment was developed, a lot of the research was done in conjunction with the training clinic that was under operation. And so this is actually an opportunity to start someplace and then see the result of that knowledge, that understanding, the work, the practice, expand outward in the community. And that's it. I'll just tell you quickly, another very short story, but I'll tell you quickly the reason there's a picture of a piano here. Increasing access to treatment, as you know, is something that Dr. Linehan was very passionate about. Learning how to teach about DBT in the community was something she required of her trainees, and it was affectionately known as the piano recital. So I will consider this a DBT piano recital. Next, we're actually going to have our guest, Dr. Faria Kamal, who is a licensed clinical psychologist in New York City and assistant professor at Columbia University Medical Center. She provides evidence-based therapy to children, adolescents, adults, and families, and her research has focused on providing effective mental health services to marginalized communities, along with the assessment and implementation of DEI practices within clinical services.
Hi everyone, it's so nice to be with all of you here today, and I wanted to be honest that without the work of the University of Washington, in particular the DBT clinic here, I certainly would not be a DBT therapist and I would not be standing before you today. Like so many of us, who got into this field and into doing DBT, we owe a tremendous debt, I think, to this clinic for all the work it has done. And part of personally for me why it's such an honor to be here with you all today, other than, in COVID, we couldn't ever do in person, so it's just nice to see people's faces, is I'm gonna share an open secret in DBT that I think many of you may not actually know, which is this clinic and University of Washington are essentially the bedrock and heart of DBT. or, as Gen Z patients of mine would say, legends only here. And so they've long set, the gold standard for how we do DBT. They've produced some of the most important and impressive research that we use to support our patients, both nationally and internationally. And it's a place that's created the conditions, as you saw before you today, so that a new generation of DBT therapists and new DBT rock stars can emerge. And as is often the case with DBT providers such as myself, I wanted to start with a mindfulness activity. So I'm going to show you an art piece, and I want you to just pay close attention to, what captures your eyes, the colors, patterns, if you have positive or negative judgments about any of this, and what feelings it brings up in you. So, anyone brave enough to share an observation that you have? Yeah.
It looked like a shattered TV, like a flat screen TV when they get shattered.
Yes, they're shattered parts of it. I saw a hand somewhere here, yes. Unsettling. Yeah, it's a piece by Los Angeles artist Mark Bradford, and he entitled it Los Moscos, the flies. And it takes its name from a derogatory slang term that refers to California's undocumented labor, so those who are working and living without formal legal immigration status here. And at first glance, what this collage suggests is a view of the city's nightlights from the air. And on closer inspection, if you look at it right now, it actually reveals deeper ironies. You'll notice that there's radial patterns visible throughout the canvas that suggest helicopter blades over a city that is constantly under surveillance. And yet, the individuals, whom the work is intended to portray, the undocumented workers, remain hidden from view, unseen, and in the darkness. And this metaphorical frustration, which is really about an existent yet invisible population. Such ironies are, the hallmark and frank reality of doing equity work. The most needy populations are usually the least accessible and visible to us, whether that's for legal, political, social, or programmatic reasons. And what I really appreciate about Mark Bradford's piece is it warns us of the pitfalls of attending only to vivid colors and bright lights. Instead, drawing us towards the darkness and inviting us to focus more closely on people and populations that he labels as living under the radar, or in other words, to pay closer attention to those who are systematically ignored. And that is really the work of mental health equity, is who is systematically ignored, who is in the dark, and who is not visible to us. And so when I think about health and mental health within it, I think I really conceptualize it as a kind of social mirror. And like any other mirror, it reflects information back to each of us. And as a social mirror, what the study of health can do is it tells us a great deal about the state of our society, about the kinds of problems that we're grappling with, and how we might tackle those problems. And I think the COVID-19 pandemic provides a pretty intuitive example for us here. So we've heard repeatedly about how the pandemic exposed fault lines in our society, so to speak, and that those fault lines in turn have really animated some pressing questions about population health and ultimately about health equity in the world we live in. So if you look at this figure here, it's COVID deaths sorted by race. And what you'll see is Black Americans in orange had double the death rates of whites. And the most obvious question then, of course, is why? Why are some groups at greater risk of infection and death from COVID-19, while other groups have been mostly sheltered, from the pandemic and its associated harms? And what the science of public health actually shows us, and what the pandemic has really clearly articulated, is that the problem of who falls sick in our society and who dies and why they die is fundamentally a question of societal resources. Who has a good job? Who lives in stable housing? Who can afford to take time off? What kind of workers actually have paid sick time? And so on and so forth. And so people really experience different levels of risk and death in the pandemic because society afforded, people different levels of access to valuable resources. And those resources included power, status, money, and knowledge. And the same trends are seen when we examine mental health as a kind of social mirror. So when we examine mental health as a social mirror reflecting information again back to us, what we see here in this figure is that disproportionately specific communities, so Latin communities, Asian communities, and Black communities, struggled more than whites with mental health during the actual pandemic. And were more likely to screen positive during that period for both anxiety and depression. And if this data in this study had included Native communities, what we would have seen is Native communities actually fared the worst of all communities during the pandemic. And if it was included on this chart, what it would show is that 65% of Native populations in the US would have screened positive for both anxiety and depression. So I want to ask a question, so please raise your hand for this one. How many folks here are in any way surprised by this? Any hands? Okay. Right, the majority of us here today are not. And that's important because there's an interesting finding that comes after this study. So Nguyen et al., with a sample size of 700,000, found and replicated exactly this finding studies, right? So essentially that the burden is on racial and ethnic minorities, predominantly Black, Indigenous, and Latin populations are more likely to screen positive for anxiety and depression. So after that is where the study gets really interesting. When the researchers adjusted for only 3 things, income, neighborhood, and access to health care, there were minimal to no racial differences found in the data set. And this tells us something extremely important about our system. It is a story of how mental health is informed by the social resources we have access to, otherwise known as the social determinants of health. And it tells us something about what we can do here, which is we can make mental health outcomes much more equitable merely by addressing the social components and resource issues that are affecting people's lives. So, as many of you, I think, will probably intuitively understand, societal resources are essentially things like income, wealth, education, stable housing, access to health care. And in the research, this is really referred to as a social determinants of health. And what we know from decades of scientific research is that the great majority of avoidable deaths and health issues in our country are directly attributable to these social determinants of health. So that's the everyday social and economic conditions in which people are born into, grow up within, live and work within. And so I want to ask a question, and we're going to do a little survey poll, and since we're not on Zoom, I actually get to see this live. So I'm going to give you 3 options, and I want you to think about, based on what you've just heard, what do you think has a greater impact on your health? So the options are a healthy diet, eating a lot of leafy greens, broccoli, all the things our parents taught us to do when we were younger, working out 5 times a week, or living in the right zip code. So all those who say broccoli, leafy greens. I'm here for it. I know I'm in the Pacific Northwest. There's a lot of, memes about you guys, so I'm not going to assume. So anyone feel the leafy greens and healthy diet is the most important? Okay. 5 times a week exercise. Wow, tough crowd. No one's going for the exercise. Okay. Your zip code. Smart crowd. Very smart crowd. Yes, the number one determinant of your health is actually your zip code, because it is the most associated with these 5 areas that socially determine our health. And so I share this with you because I don't want my nieces and nephews to use this as a way to not eat the greens I give them. So I want you to take a good look at this wheel, and I want you to remember these 5 areas, okay? And here's why: because we are at a university, and I get the joy of giving you a pop quiz. Yeah. So this chart, what it's showing us is all the possible factors that influence health and mental health outcomes. So the last one was socially determined factors. This is now all the factors that can, that impact people's health outcomes today. So, taken together, what percentage of this do you think is socially determined based on the 5 categories that we showed you? Percentages, throw some out. Sorry, who said that? You get a trophy. I don't have one, but you get one. So excellent job remembering. You got A+ for this pop quiz. So 90%. That means 90% of why we see the kinds of statistics on inequity, 90%, of like the differential and worse outcomes that we see in communities of color and marginalized community, 90% of that is changeable, fixable, and shapeable by all of us here in this room. And mental health and health inequities do not come out of nowhere. They are actually not accidental. They aren't random in how they are impacting people. On the contrary, they're extremely rooted in decision making. They're the outcome of how policies are designed and devised, and what values we choose to honor, whether it's at our universities, at our clinics, at our hospitals, at our personal jobs, because they determine who can access our facilities ultimately. And so, why focus on the social determinants of mental health as we talk about equity today? At baseline, what equity means simply is just about fairness in the way people are treated. And mental health equity then is about us first understanding, what is getting in the way of fairness, and equipped with that knowledge, correcting these imbalances to make mental health care ultimately fairer, more just, and more accessible for all populations. So the social determinants of mental health, I think, provides a really important framework for mental health providers and, all of us here in this room, because, it demands we address not just issues on an individual level in therapy, but that we also take into account structural issues that are impacting and impeding the mental health of our communities and patients. And similar to how Dr. Forsyth Cox highlighted the work of the MML clinic and the importance of issues like transportation. How are patients getting to session? What are the session costs? How are we managing, insurance challenges? What are the linguistic barriers people are facing? Because ultimately, we can't do good therapy in session without also addressing the structural issues making the lives of our patients a living hell. And this framework allows us to understand that it's not individual gains versus structural gains. It's about individual therapy and structural interventions for us all. If we understand structural barriers, it changes the terrain of how we work in psychology. And a lot of people think when we talk about social determinants of health, it only impacts, marginalized communities. It doesn't impact, wealthier communities. And I want to be clear here is that it actually impacts us all in different ways. And I want to give you a few examples to highlight this. So the first example, I'm going to ask for audience participation again because it's exciting times post-COVID to see you all in person. What do you think most individuals in Western countries report as their largest source of stress? Yeah. Wow, I'm very impressed. This audience is very sharp. Usually people say things like child rearing, finances, family is usually a top one. So yes, you nailed it here. Is 60% of Americans report work as their primary stressor. And the interesting part is it cuts across all demographics, whether it's age, race, ethnicity, sexual orientation. So basically, we are all united in this one front of work stress. And as adults, we're going to allocate more time to work than any other daily activity in our lives. And I think perhaps because it consumes most of our waking hours, what we know in the research is if we aren't busy doing work, we're really busy worrying about doing work, right? And, to give you a really important study that came out, the Workforce Institute found that bosses or managers had more of an impact on an individual's mental health than their doctor or therapist. Yeah, we're laughing because we all feel it, right? We've all been there. And to put it into context, because I think sometimes stats really needs to be contextualized for us to get it, that same study, when it looked at the effects of people on our lives, your manager or your boss has the same impact on you as does your life partner. That's the level of impact we're talking about. And this is really important for us because traditional therapeutic frameworks, we kind of teach patients, what do? We engage in self-care practices, right? So how can you self-care your way through this? And it's important. And from a social determinants of mental health framework, it means that we also help patients understand that a toxic boss, just like being a toxic partnership, impacts mental health negatively, and we cannot self-care our way out of a structural issue. Yes, I feel like Gen Z is here because this is like a Gen Z vibe and audience. I'm feeling it because this is my patient population that I love the most. And if we take another example, so I initially trained in child and adolescent, so that's really where my heart is. And parenting work is a huge part if you are a child and adolescent therapist. And so many of you may have heard, because I feel once it hits like TikTok and the New York Times, it's going viral. But the data actually does demonstrate that there's been a significant increase in helicopter parenting. And so have people heard of this? Show of hands. Have you heard of helicopter parenting? Okay, yeah. So most of us have heard of it. It's really a style of parenting where parents are overly focused on their children and typically take too much responsibility, particularly for their successes and failures. And simply stated, it's really over-parenting in a way that is three things. It's over-controlling, it's overprotective, and it's overly perfectionistic. And I'm coming from New York City today, which anecdotally I will maintain as the global epicenter of helicopter parenting. If you look at the data though, helicopter parenting styles are most frequently observed in high SES, so like high socioeconomic, environments and white neighborhoods. They are rarely actually observed, if you look at the data, in low-income white neighborhoods. How do we account for that difference? Anyone want to take a guess? Yeah.
Well, here a lot of people have been in tech and then they retire and they're like 40 and their job is their kids.
Yes. tech just got called out in Seattle. I'm shuddering for parts of this audience. Absolutely, because what that's getting at is this is actually from a social determinants, of mental health perspective, this is about resource allocation. High SES neighborhoods that are predominantly white have tremendous resources to devote to things like overparenting. If you are a poor white parent in a single family household, you do not have the luxury simply of overparenting or to aggregate resources to spend inordinate amounts of money to ensure your children are getting into prestigious colleges. And actually, even from a social determinants of mental health, and this is why I say this impacts us all, rich and poor, is for high SES white parents, when we are providing support around helicopter parenting, part of what's needed is we need to be able to contextualize our patients' struggles, not seeing them in an individual vacuum. Actually, helicopter parenting, if you look at the data, is happening at the same time that we see a rise of essentially a model of scarcity, a model that consistently tells parents they are not doing enough. And it's essentially taking the toxic positivity movement and turning and weaponizing it against parents of what needs to constantly be done. My favorite stat in grad school was for parents, you only got to get it right 27% of the time. That's what the research shows. The other is like incidental, who cares? Live your life. And so, the social determinants of mental health provides evidence that while compassionate therapy is vital, we have to help build compassionate systems to support the work, because therapy alone isn't enough. It's why Vibe talked about helping cover transportation costs or helping patients navigate insurance boards or panels, or creating, what the MML clinic has done, which removes certain barriers. And one of the ways that I think about why social determinants of mental health is so important, and the way I personally conceptualize it, is it's this idea of freedom and what it means in psychological work. And what I mean by this is, as a Canadian, when I moved to the US, there's probably no word I have heard more on repeat in the US, doesn't matter if it's like left or right, is the word freedom. We hear it everywhere. And part of understanding social determinants of mental health is to provide population level freedom, and two types of freedom specifically. I think about it as freedom from and freedom to. And here's what I mean by that. Freedom from is about freedom from certain social constraints. So currently in our country, what we are seeing is in a very concerted, state. It is enrapturing, I think, and garnering so much support in really dangerous ways, is there's attacks on the trans community and the LGBT community in pretty significant ways. And freedom from, in the context of social determinants, is freedom essentially from oppression, right? And what freedom to is freedom to live your life and lean into your values in the ways that make sense for you. If you want to paint, paint. If you want to, go to a movie, you go to a movie. If you want to work less, that's not happening for most of us here, we would have the option to work less, right? And so part of what I want us to realize about social determinants of mental health is who actually gets both freedom to, as the way Gen Z would say, live their best life, and freedom from structural oppression are essentially the take-home winners of social determinants. And so if we focused on all the different social determinants of health, we'd be here all night, and I don't want to bore you to death. So for today's talk, I want to focus on what many of us in this room likely have the most power to impact, and that is the access part of this pie. So access to mental health care. And whether you're a concerned citizen or a mental health provider here tonight, a student, a donor, or university staff personnel, we're all in a unique position, I think, to shape this part of the pie in different ways, depending on our role, title, and social location. And so here, when we talk about access to mental health care, from a social determinants of health framework, what we're actually just discussing is what are the financial, social, and cultural barriers that determine how easily a person can obtain medical or mental health services. So again, I'm going to ask for everyone to raise their hand. How many of you, for yourself, or if you have kids, for your child, feel if you wanted mental health services, it would be easy getting treatment for you today? Show of hands. Okay. So some people. The majority of this audience did not think it was easy, and that is a national trend. For most people, accessing mental health care does not feel easy. And I want to do a little bit of a PSA before I dive into the stats component of this presentation, is that honestly, as a researcher and academic, I've often felt like I'm like the Dementor in Harry Potter, where you suck all the energy and joy out of the crowd because you just give them really persistently bad news in that way. And as a therapist, we think all emotions are naturally and frequently occurring, right? So we are not on the positive toxicity version of this. So whatever emotion you feel, whether it's despair or hopelessness or sadness, is absolutely valid. It is real and we accept it. And I want you to hold also at this moment that one of the functions of emotions is to move us to act. And so I want you to notice your emotion and let's use them to call us to act in changing these issues of access and equity. So I say this because doomsday is here now in the presentation. So I want to contextualize, the scope, and often when I feel we throw out stats, I personally myself struggle because some numbers are so large and incomprehensible that it loses value and meaning. So here, if you look at the largest, most populated cities, number 1 is New York City, where I come from. Congratulations, Seattle, you're not even on the top 10. So you don't know what it's like to battle for sidewalk space like we do in New York. But if you look at this, what you see is that SMI stands for serious mental illness. And if we look at the population in this country that struggles with serious mental illness without access to treatment, it would be our second most dense and populated city right after New York. And for our serious mental illness, we're talking about pretty severe mental health issues where treatment is absolutely vital, oftentimes life-saving. And, I want us to keep in mind that this 90% of the pattern you see here is because of policy design. It is not accidental, it is not unintentional, right? And it's the equivalent of when we know this is the scope of the crisis, the current policies that we have, it's the equivalent of we know people are dying because there's a water shortage in the city and people don't have access to water. And why don't they have it? It's been diverted to a wealthier, more affluent suburb. That's the scope of the crisis we're seeing. So I want to start this by saying I truly debated whether or not to have the title of this stat slide be an ode to Taylor Swift with, "Hi, it's me, the mental health crisis, I'm here." And then I worried that I was on the West Coast and all of you would think, wow, these New Yorkers are really alarmist, which we are. And you'd be right, except that, just so you understand my rationale, it's not just because I love Taylor Swift, it's that in a recent 2022 poll conducted by Kaiser and CNN, 90% of Americans reported that the US is experiencing a mental health crisis. And what this graph here is showing you is not serious mental illness, but just the percentage of adults with any kind of mental health issue who received any service at all. So it's not necessarily the right service, it's not, the effective treatment. It may not even have been rated helpful by the patient. Just, did you get anything at all? And Out of all of the people that needed services, this is a breakdown of who actually received it based on race and ethnicity. So at best, again, remember, I'm not trying to be a dementor, these are just the stats. The news is that our mental health system is currently not supporting almost half of all white people who need access to treatment. That's the best thing we've got. And if you look at racial and ethnic minorities, we're not servicing 60 to 75% of all patients who need treatment. So I don't think this is, a surprise to any of us that access to mental health care is not equal across populations. And this is really the elephant of an equity issue in mental health, is really access. And I'm going to break down, access to mental health by population. And I just want you to repeat in your head as we go through this: despair is an emotion. It is not a doom and gloom, action plan. It is not policy. It's just an emotion, and we can feel it, and we can be called to act on it. So before I go into accessibility rates for Native population, I want to first say that, for any of us, I think understanding mental health, the needs of this particular population are greater, I think, than that of the general population in our country, across the board, irrespective of what mental health illness we're looking at. And that's for a host of reasons that the social determinants of mental health actually provide the best explanation for, right? This is a population oftentimes in extreme poverty, residing in rural or tribal lands where access to providers are scant, if any. Oftentimes services are extremely limited and underfunded. And there's a really justified, I think, mistrust of government services and traditional Western mental health practices in these communities. It does not bear me saying that the history of genocide in this country would likely make any of us not trust, systems. So remember what we talked about at the outset, that 90% of the inequities that we are going to talk about and see here are really due to these social determinants of health. And so what it's resulted in terms of mental health issues in this population is there's twice the rate of PTSD in Native populations. They have the highest rates of lifetime major depressive episodes and the highest self-reported depression rates than any other ethnic or racial group in this country. There's also, because we are at UW and there's a lot of researchers here on suicide, there's higher rates of suicide in the 10 to 34-year-old cohort. They're the highest cohort of suicides that we've seen recently. And now for the good news, because I promised I wasn't a dementor, is when we look at this chart is really showing us available data in a 10-year period between 2005 and 2014 and 15. And the good news here is there's actually comparable rates, if you look, of access overall, similar rates to whites using services in mental health. And then that's where the figure is misleading, but I tried to give some good news first. Is the more troubling picture when we break down by subsets struggling most with mental health in this population is that the majority of Native youth who are at risk of suicide actually reported limited to no access for specialized services like DBT and the services that are provided here. Youth and those under 34 were most likely to be uninsured, so the population most at risk of suicide is also the population least likely to have insurance to cover that. And 33% of this population at any given time remains uninsured. So when we look at rural populations compared to metropolitan cities, we see that there's significant shortages across the board in having access to any mental health providers. Patients often report needing to travel 1.5 hours as the average each way for the closest mental health care. And this is in the context of rural suicide rates having increased by 48% in the past decade. While the picture's not getting any rosier for the LGBT population, unshockingly, is what you can see in this chart is 60% of this community can't access services. And this is in the context of higher rates of suicide, depression, and anxiety. And then my favorite, teenagers, is here's where we get some good news. And what we've found is teens in the US have more availability of mental health care than they did 2 years ago. So that is really good news. The news that you are also witnessing in this chart is access is not equal in all communities, right? So in blue, we have white populations. In orange, we have BIPOC adolescents. And there's a huge difference between white and BIPOC adolescents' access to mental health support. So what's the impact of all of this, right? Is one, I want you to, and this is really a sad part of our job, but we know for many of us in mental health intuitively this, but the average delay in anyone in marginalized communities between onset, when they first experience mental health symptoms, and when they receive treatment is 8 to 10 years. So we're basically looking at a delay of a decade. And because of that delay, these impacts are really pervasive in marginalized communities. So you'll see that there's, billions in lost earnings per year for people who have serious mental illness, 116,000 deaths between 2016 and 2020. These were considered preventable deaths if mental health services had been provided in these 4 years. And I think the most outrageous one, to me personally, was I didn't even understand what 400 billion meant because that's monopoly money at that point, right? I'm just like, what is 400 billion? And then I thought to myself, I'm in Seattle, home to Amazon, right? Everyone here is familiar with Amazon. What do you think Amazon's revenue in 2021 was? Anyone want to guess? I know there's tech people here. Anyone want to throw out a number? No one's like, I don't want to throw out any numbers. Yes, exactly. So it was 469 billion. Amazon is in the top 5 richest companies globally. Each year, we are seeing a 400 billion loss in racialized communities because of untreated mental health. That means our communities could have Amazon money. We could be making it rain in all these other ways. We could be the Jeff Bezos, and here we are, right? So I want you to just contextualize, this is Amazon money, essentially, we're losing every year. And so what, is really getting in the way of mental health access? Why are we experiencing these kinds of impacts? And I think Vibe covered a lot of this, so I'm going to go a little bit faster for this part. So this chart is showing us self-reported. So this is what, essentially people are reporting themselves about difficulties in accessing mental health. So one is I want to share the good news first, again, is cost remains, as you can see, the number one reason why people cannot access services, and less people feel cost is a barrier than before. So that's pretty great. So in 2008, it was more of a barrier than it is today. So we're at least trending in the right direction. And now for the bad news, because it's here. More Americans reported having unmet mental health needs than ever before. So that part of we're in a mental health crisis in this country. And I show you this slide because if you look at it from a social determinants of mental health perspective, it's about evenly distributed. Half the reasons are individual and personal reasons, and half of them are structural reasons. Now, what happens when we look at communities that are marginalized. Oops. So if we look at LGBT community self-reported difficulties in accessing mental health, what you will notice is almost every single reason here is a socially determined reason. And that's different from the general population. So what we know is the more marginalized a community is, the more structural barriers they're actually facing. So that's what we were talking about before. Oftentimes, there's no freedom from oppression, and there's no freedom to actually live your life in the ways that are meaningful to you. And I wanted to share, because I found this really interesting, is this is true not just for obviously the LGBT community, it's true for most marginalized identity groups across the board. And there's been a pretty interesting shift if you look at the data in most BIPOC communities. Sadly, my community of Asians not included in that, so other than Asians, this applies to all other BIPOC communities, is 10 years ago what the research showed is that the top reason BIPOC communities were not accessing mental health services was due to stigma of mental health or fear that others in our community would judge us negatively, or oftentimes that it meant something terrible and negative about ourselves if we access these services. 10 years later, when we look at the aggregate data, there are almost no racial differences found among reason for not using mental health services among BIPOC communities. And actually for BIPOC communities, the least frequently cited reason for not using mental health services across all racial and ethnic groups except for Asians, the least was the belief that mental health wouldn't be helpful or effective. So now that we know what individuals report are their personal barriers to mental health care, what does the data and research show us are the specific barriers in this country? Is it showing us the same patterns that patients are reporting, or is it showing us something different? And so the answer is it's showing us there's overlap, some of the same issues. There's also other things that are in the picture. And what I want to point out is all 5 of these are socially determined. So there's not a single thing here that is not a structural difficulty. So the first one is obviously cost. So in this country, 61% of adults do not have adequate mental health coverage, and 12% have no coverage at all. So we're essentially looking at 73%, which is 3/4 of our population, who are impacted due to no or poor coverage in mental health. And one of the other things that's really important about cost, and I think Vibe highlighted this really nicely, is the majority of specialized providers in our country, including many DBT providers, don't accept insurance and are private, which means paying out of pocket, and it's an immense burden and cost associated with that. There's also the issue that there is not enough mental health providers. So 150 million Americans live in areas where there are either no or very scarce mental health providers. And 77% of counties across the US currently report in 2023 that there are severe shortages of behavioral health professionals in their community. And to kind of contextualize what this means, a recent Harvard study, found that just 17% of phone calls potential patients place to get an appointment with a mental health provider were successful in securing an appointment. There's also, lack of training in mental health. So when we look at the mental health providers that we currently have available, we also see that there is not enough who are trained in areas like DBT, managing suicide risk. We know that there's not enough who are able to treat psychosis and many other high-risk kinds of behaviors. The next area is cultural competency and fit. And this is really, poor cultural awareness and understanding even within the providers that are available. And it's important because different cultures have different ways to describe mental illness and have different ideas about when or how we intervene. And it means that we have a real dearth of services in this country that is culturally competent. 86% of psychologists in the US workforce were white. And the number one concern for BIPOC college students accessing mental health resources at places like University of Washington is the lack of diversity among healthcare professionals. And ultimately, I think this was best summarized by Martin Diaz, who was a UCLA student, who asked the question, can psychologists who don't look like me understand my experience? And I say this also because I think cultural competency is not, most of us could go to trainings and we can tick off boxes. And if you're here in the audience, you're probably really good at test taking. We are proficient in that element. But cultural competency encompasses so much more than that, right? And I want to give you 2 examples to help illustrate what we mean by this in our field. When I was a graduate student, one of the really cool things you get to do as a graduate student is you get to throw out an idea and people say, let's give you some money to try it out, and that never happens in other places in life. So it was really exciting because I got funding to run this thing called the Chai Hour. And it was really designed because in Toronto, which is where I was at the time, there was a huge difference in South Asians accessing mental health. It was very negligent. At the time, it was less than 10% of South Asians accessing services in a population, if you think about who needed it. And so Chai Hour was essentially a covert operation. I felt like a little bit of a CIA agent of getting people to do group therapy without calling it group therapy. And so what we had is we had this drop-in hour, and it was every week, and people in the community could come, and we just served tea and biscuits. And I know, like, most people think, oh, that sounds really British. Who do you think they got it from? Not their idea. We had this hour where we served tea and biscuits, and they could come and they could talk and they could chat. And it was a really successful program because essentially they came and chatted about what things were stressing them out, what resources they needed, what they didn't have access to, and what they could do. So essentially all the traditional elements of a support group without calling it one. And one of my most recent patients, who was a South Asian woman who was about 68, she had no prior history of anxiety. And suddenly following, actually like a medical vertigo episode, became increasingly anxious and paranoid about leaving her house. She refused to go down the stairs. She refused to hold her grandchildren because she was always afraid she might drop them because of the vertigo episode. And her quality of life had really declined. She stopped driving. She stopped leaving her house. She refused to visit her grandchildren. They had to come to her. And the family came and said, we tried going to other providers. It's not working. Something's not working. And so I thought to myself, well, I know a lot of 68-year-old, South Asian grandparents, and what can we do to get them to do something? Essentially use their grandkids as bait, like any other grandparents, right? And so what we did is I essentially, our offices are very close to Central Park. And so she wasn't leaving her house. She refused to see medical providers. And they decided that they were going to bring the kids to Central Park. And this was a huge thing for them because the kids live in Connecticut. And even though Connecticut's so close to the city, people think it's like a different universe in New York City. So the kids were super excited to go to the city, and they begged their grandma to come. And so then their child, who's like a 40-year-old person, is like, oh, well, there's this other mental health provider, and she's going to come visit us. So it was like kind of a sneak attack in some ways. And, I think in traditional models, we'd be like, oh, was that ethical? Was that not, right? And what I did was I met with her, and I realized that because of the way I looked, she just referred to me as Beta, which is a term of endearment in the South Asian community of, little one, or, son or daughter. It's an affectionate term. And so I was like, great, I'm gonna call her auntie, which we do to everyone and their mother. And we got her to do exposures based on, you know, her only goal, which was hanging out and seeing her grandchildren. And so when we talk about cultural competency, we're talking about understanding communities enough to know how to deliver modes of treatment. You cannot just go into this grandmother and be like, hey, we're gonna do some exposure therapy, buckle up, buttercup. You know, like it's not gonna work, right? So when we think about these interventions, it's how do you deliver them to this community in a way that resonates, and I needed to do it in a deferential way. She's an elder, I have to act accordingly. And so the last area is around social stigma, and I think, you know, stigma has been identified as one of the primary barriers to access and receiving equitable quality of care. So this is really about the stigma of mental illness. Oftentimes it discourages, you know, open conversations about mental health and implies that mental health is really shameful. It perpetuates incorrect myths about those experiencing mental illness. You know, the common one is, oh my God, people who are mentally ill are somehow dangerous, and enforces the idea that people with mental health issues should somehow be avoided. I'd like to say I think we have made much progress in this area. Shout out to like Gen Z in this room. Thank you, because you brag about your therapist every other video on TikTok. So we're at least getting somewhere. And so what can we do about this? So for each of these areas, because these are structural things that we need to deal with, we need structural interventions. And these are kind of some of the structural interventions that I think many of us in this room here today can at least wrap our minds around. So for cost, you know, this is what Vibe was already talking about, of how university clinics are a bedrock in terms of access and public health in many ways. And so donations, grants, university clinics, I think in that model is really important to reducing that barrier. In terms of not enough mental health providers, there's tons of models that are showing that we can actually train community workers. So similar to what folks here were talking about, of training EMS personnel or the police to behave in certain ways, we can do those kind of trainings and like at low cost, and essentially train a different workforce of providers to provide effective low-cost solutions. I think virtual visits, as much as I hate like Zoom sometimes and just want to like online shop as people are speaking, virtual visits have actually shown really a huge efficacy in reducing barriers to care, particularly in rural communities and isolated communities. And I think that's been one of the benefits of the pandemic, is accessibility. Then in terms of lack of training in mental health, I think the UW clinic has a really great training model. And this is a kind of training model that I think is really beneficial in training mental health providers to do high risk and I think like high reward work. And for those of you, you know, I think like UW doesn't brag about itself enough in these ways. But my first venture into DBT was because I saw a DBT video that was produced here at UW, and that was part of what inspired me to do DBT, because I thought to myself, I want to be that good. Because when you see like rock stars perform therapy, as a graduate student, you realize how terrible you are and you cry in the room, but after that, it gets better. For cultural competency and fit, we want to recruit more BIPOC providers and really increase trainings in this area. And to reduce stigma, actually one of the most evidence-based, you know, effective things we can do is go out into the community and talk to people. Therapy is, you know, think about if there's a black curtain on stage and you can't see behind it. That's what therapy feels like to most people. They have no idea what they're walking into, right? The more we can show that, hey, like, this is what I look like. I promise I'm not super weird as a therapist. And one of the really interesting ways that people have done outreach is a New York study had a study where they looked at if therapists and mental health providers went into the community to like barber shops, to beauty salons, if they went to libraries or schools, to where people actually are who aren't servicing, getting services from us, and they just were present. You don't even have to be charming. You just really have to be present. They saw a huge, responsiveness and access to services. So I think these are ways that we can, address these issues. And now we are in the questions part.
Is my mic on?
Yeah.
Okay. I just want to first thank our two speakers here for enlightening us with so much information. But it's, not information about the nature of the problem and what we can do about it. It's just very inspiring for both of them. So thank you, thank you. I see we already have a question, so I'm actually going to move to our questions here. And if you have questions, please come to the mic. We have one over there as well as over here.
Since it seems that DBT is a very sort of systematized and specific kind of training, I was wondering if it would be sort of considered blasphemous to not limit it to the sort of academic graduate school environment and actually train people to do this therapy. I don't just mean as part of their jobs as police or whatever, but literally to go out and train lay people to be therapists. I don't know if the model would be trade school or what exactly the model would be, or a certificate program, but nothing to do with grad school, just to sort of spread the skill and the availability around.
I think that's an excellent question, and I appreciate it very much. I think that one of the things we're hoping to do is make sure that we can increase the availability of resources for everyone, and I don't think it's blasphemous at all. I think people are looking for ways that they can find effective ways for all kinds of people, lay people, to be included in the treatment process, because that's a big way of how we can increase access to treatment. I think the important thing is to figure out how that would look in a way that would be most effective for the communities that we're trying to serve. But I don't think it's impossible.
So are there other questions that people might have? It's a really important question to consider, how we can get it out there
I think
more.
there's a person.
Oh, yeah.
I was wondering if there's a way for undergraduate students or postgrad students to get involved with this as well.
Yeah, absolutely. I think probably the best thing to do, if you're interested or you know someone who's interested, is to send an email to dbtclinic@uw.edu, and that way we could talk more specifically about what the options might be.
Thank you so much.
I have a question. I was wondering if DBT is just about providing access, or if there's something more to it. If there's like something specific about the manner of therapy that you provide. Just giving people a Zoom link.
Yeah, there's actually a lot. It's considered, some people consider it to be a complex treatment. And so I can't necessarily teach it all in the moment, but I would say that at its core, DBT is about helping people identify what do you want to get into your life that would make you experience your life as worth living, and then what has been in the way. And once we figure out what has been in the way, then we help people learn the skills they need to solve those problems, and then practice those skills in all the different places they need to get practiced to be able to make those changes. And the therapist is there to support that process. The skills training group is there to help build you that toolbox. And so that's kind of the idea, is that some people, for whatever reason, may not have gotten a chance to learn or practice all the skills that they need, and sometimes are punished for doing things that are actually the things that would help them in other circumstances. And so really being able to provide people the environment and the opportunity to learn and practice the skills that they need to make the changes they want to make. And so that's kind of, in a nutshell, the work that we're trying to do in DBT. Yeah.
Go ahead.
So my question is related to individuals that have like a severe mental illness that maybe they've even been diagnosed, but because they don't believe they have an issue, it's a barrier to have access to all this because they just say no. I noticed in your statistics, that's kind of like the second biggest thing is refusing treatment. Oftentimes it ends up they get in trouble and they get treated in jail when they get their first treatment. And maybe that's why it takes 8 years to get treatment. Do you have any thoughts about how we can overcome that? Because I think you mentioned freedom. I think individual freedom's important, but sometimes that has to be trumped. But you can't. It's a big barrier.
Absolutely.
Oh, go ahead. Yeah, so I apologize because I may have misspoken. What I was trying to show is that the second most populous city would be serious mental illness that's been untreated, not necessarily people who are refusing treatment, but those who can't get access to treatment and have serious mental illness. You know, I think when we understand serious mental illness, it makes sense that many people with serious mental illness actually don't want services. And I think it's important to understand the validity in what are some of the reasons why people don't want services, right? Oftentimes, their experience with service providers are not great, or the mental health system or the medical system is really problematic. One of my patients was untreated for about 14 years for a pretty serious mental illness and had refused care. And when we actually inquired as to why, I think part of it is us getting curious, but what we know from the data is these negative experience and these like micro moments of negative experience, right, with providers, with systems, really discourages people. And if we can solve for some of those systemic issues, right, of it's really laborious to get care, to do research on what provider is going to meet that specific issue. And oftentimes, if a patient is having to go through 2, 3, 4 people and everyone is saying, oh, actually, that's not my area of specialty, maybe try here, right? And that's oftentimes what happens with serious mental illness, or people are just hospitalized, right? It gets to a point where it's so severe that the only thing standing between families is an emergency hospitalization. And what does that mean for patients? It means that they're essentially going into a level of care that is the most intensive and oftentimes reported as the least empowering, right? Is emergency rooms are not equipped to handle these kinds of issues, and they're oftentimes the ones having to. So I think for me, it's a systems issue and not an individual issue. I think, one, we need to do a better job of outreaching to communities. I think we need to make it less scary around mental health. And I think for emergency rooms in particular that see this population, I think we need to do a better job of triaging into direct service providers who can address this issue and do it in a non-judgmental way. And if the patient isn't willing to get support, we can help the family learn to manage the issue around the patient.
I think I want to add on to that a little bit too. I think all of those answers are excellent in thinking about the ways that families and communities can be empowered to provide support. I think it's also related to a question that we received a bit earlier. I think this is actually an area where peer support can be helpful. Somebody who's actually managed those kinds of problems with serious mental illness before to say, yes, right, I was like you, I had some of the experiences you had, and here's what was helpful for me about actually talking to someone and getting mental health treatment. I think that's a really important use of peer support in the way that I think someone before was mentioning. So I think that could be helpful too.
Great, thanks. Go ahead. If you can speak directly in the mic so that everybody can hear this.
Okay, I'll do my best. I got a little bit of social anxiety, so I'm doing what I can.
You're in a crowd of therapists.
Yeah.
Great job. Great exposure.
So I'm a mental health provider in a school-based health center, and I work with middle school age kids primarily. And social determinants of health is my new rally. If you see now an emotion, it's rage. A lot of the kids that are coming to me are anxious, depressed, freaking out. And 9 times out of 10, it's because they don't have enough food, they're not getting enough sleep, or they don't know how to read. And I'm sitting here going, all right, anxiety and depression are probably there, but how much of it would be settled if we could actually teach you how to read? How much would it be if I could get you enough water? How much could it be if you could get enough sleep? So I really appreciate you bringing that to the screen today. And again, as a mental health therapist, scope of practice, what can you do rather, I'm a Hulk, so I go and Hulk smash, but like, how do you create the community to help these kids, specifically kids? So there you go. Good luck.
Yeah, I mean, I think that's a great question that I think most of us who work in school settings or public hospitals really face every day, right? Is how much of this is a therapeutic issue versus how much of this can be resolved if we got people essentially the 5 social determinants of health. So I think this really challenges us as providers to become advocates within a system. I think there's a lot of things we can do when we get creative. So when I was working in my postdoc in a psychosis clinic, the majority of the patients I was seeing, I wasn't sure it was a first episode, psychotic episode, versus actually that there was really unstable housing. Oftentimes, the places of residence were so poorly kept by landlords. There was a huge problem in New Haven around lead poisoning, the water, mold growing. And what we did is we created a partnership with the Yale School of Law because it's a lot more terrifying as a landlord to get a notice from Yale Law School than to get one from a patient. And what we saw is there were huge, when we were doing a pilot study at the time, there were huge things that you can do in terms of linking with legal clinics and schools. There's a lot of data around that that's really helpful, medical clinics and legal clinics working together. So I think those are like concrete things. And I think ultimately it's also important to just recognize and validate for people that actually this is not an attentional deficit. This is people not having enough food, right? I think one of the best interventions we can do is actually be honest with people of what we're seeing and advocate on a systems level, even if it's at our school, that we need to increase funding in certain areas, and we need to push and fight like hell to do it. It's not this passive process where it just happens. I'm currently at Columbia, and one of the things that was said is I think they were going to, external consultants were supposed to come in, and I don't know if you guys know this, but they pay tens of thousands to hundreds of thousands in systems for mental health consultants. And our team fought like hell of, no, give that money for patient care to BIPOC communities. We would rather just have free care. And it's not an easy fight, but I think it's one that's worth fighting for.
We'll have time for maybe one more question.
So my main mission in life has been and continues to increase accessibility to DBT. I'm about to wrap up my DBT training clinic practicum experience at Green Lake as an MSW student. What do you suggest as students like myself who's graduating in June as my next stepping stone, especially since I'm not a PhD student and may be limited in research opportunities?
Do you want to take that as a supervisor? Sure. I think, number one, you can email us. I think that's a great step. And I also think that, there are opportunities for people from all different types of disciplines to increase access to care. This is really an all hands on deck situation. And so looking at knowing what you do and knowing what you have been trained to do and knowing what you do well, and then looking at the places where there is need and figuring out, okay, where are my skills best suited to that need? And figuring out if there are people who you see that are doing work that you're really interested in doing, whether you see someone who's into teaching and training, whether you see someone who's doing advocacy work, whether you see someone who's working in first responders, things like that. Find someone who's doing something that you're interested in doing, and then ask them if you can help.
Thank you.
Well, once again, I just want to thank our two speakers for really engaging and wonderful talks. And on such important topics. I know, so if some of you still have questions, then feel free to come on down and speak to our speakers here. We just want to kind of cut it at this point, just kind of to respect your time since we're supposed to end at 9 o'clock. So again, thank you for coming.